You guys look great.
I didn't check my hair.
You guys look amazing. So yeah. All right, thank you everyone for showing up. My name is William, and I'm one of the head directors here at Healthhacks. And we've been running Healthhacks since 2020, and that was during the pandemic. So our first event was online, but we bring people from all different backgrounds, from doctors, engineers, students, for 48 hours to kind of revolutionize the healthcare scene. And yeah, like this is our fourth year doing it, and last year we held our first in-person event here at Stanford Research Park. And now we're gonna bring it here at the Stanford Engineering Quad. And yeah, we're super thankful to be joined by some speakers here who will provide some guidance on some of the tracks that we have over the event. And so we have 3 tracks. The first is population and preventative health, and then aging, longevity, and mental health. And then today we'll be specifically targeting the last 2, so aging, longevity, and mental health. Yeah, and then here we have today, so first we have Dr. Steve Chan. He is the co-founder and CTO of Async Health, a University of California spin-off backed by Berkeley Skydeck. And then he's also a clinical assistant professor at the Stanford University School of Medicine. So let's give a warm welcome to Yeah, and then we also have Tim Eppenberger. He's a principal, Tom, sorry.
That's okay.
Yeah, he's the principal consultant at Kaiser Permanente, and he's working with the continuum care of care at the home technologies team there. So, and lastly, we have Colby, who is the Colby Takeda, the co-founder and CEO of Pear Suite. So, yeah, we're super happy that you guys have joined us here today. Yeah, I guess you guys want to introduce yourself a bit more, like maybe give some more background on maybe how you guys came to where you are now, and yeah.
Absolutely. So my name is Steve Chan. I'm a physician who's boarded in clinical informatics, addiction medicine, and psychiatry. And part of what I do is train the next generation of physicians and clinicians over at a nearby hospital that's affiliated with Stanford University. And we treat folks with addictions and substance use disorders with our intensive outpatient program and our medication clinic. My other hat that I wear is as co-founder and chief technology officer of Async Health, where we're essentially making the waitlist a thing of the past for mental health care. One of the things that we found is that physicians and clinicians often wait around for folks to show up for their appointments, or they may not make it. So we're essentially using video clips and video interviewing of patients so that psychiatrists and psychologists can watch and evaluate and automate much of the process that causes mental health care to kind of fall apart currently. So that's Async Health, and we are working with Berkeley Skydeck, and it's been a real treat. So.
All right, good evening. I'm Tom Eppenberger. I am, as I said, a principal consultant with the Continuum of Care and Care at Home Technologies team at Kaiser Permanente. We're part of the IT organization specifically focused on care delivery. I've been at KP for a little over 10 years now. Have had a real opportunity and privilege to work in the National Innovation team. Was part of the Garfield Center that Stephen had a chance to look at, which is in San Leandro. It's Kaiser's National Innovation Lab, and have just had a real great time there in terms of getting to work sort of shoulder to shoulder with clinicians, people across our care teams to really try to think about how we make improvements in the care model and the delivery system at KP. We have a lot of work still to do. And before that, I spent about 15 years as a consultant working with medical device startups, educational customers, and also city government. So quite I guess I like politics and dealing with ambiguous issues, I think is my background. So thank you.
All right, everyone. Colby Takeda, co-founder and CEO of Pear Suite. So we're essentially building a care navigation platform for community health workers. My background is actually in aging. I started off working in senior living, so I worked in an assisted living facility At 25, ran the building and opened it up from scratch, and so hired our first 90 employees and took care of 150 residents. What an experience, at being such a young age. And it was kind of this cool dynamic of this young person running a building full of older adults, and how do we, bring them life and excitement and help them age gracefully in a setting that was institutional. After that, I actually worked for ShareCare, a digital health company, focused on the Blue Zones project. Anybody know what the Blue Zones project is? Blue zones are places that people live the longest, and places where people like Sardinia, Italy, and Korea, Greece, and Okinawa, Japan, where they found it wasn't because of necessarily the healthcare system, but it was like natural things like how they eat, how they move naturally in the community, the settings and the social connections which they build. And so in the U.S., we're trying to bring the Blue Zone principles to the U.S., and I worked on that for many years, and essentially found out that there's an opportunity to kind of innovate and do something on my own. So we started Pear Suite or maybe 2 years now, actually, 2021. My other background is in public health. So I went to a school down the road that's not as good as Stanford, of course, but just kidding. I went to Berkeley for my public health degree, and I also did an MBA, and essentially started a doctor program as well at Columbia during the pandemic, and still working on that while building the company. Thanks.
You can keep it over there. I guess we can start with you. So we have like a diverse kind of people from different healthcare regions, and then I guess like we can focus on aging and longevity. And then the first question is kind of like, as the population ages and the burden of chronic diseases increases as well, what do you think could be done to help manage this kind of the issue for the future?
Big question. Wow. Where do we start? I think it's interesting. I think the pandemic revealed a lot of areas that we can improve on with older adults and the care they deserve. I think traditionally there were these communities like senior living, assisted living, nursing home, skilled nursing care. That was kind of the answer. You find a place where they can live, and it's what we call institutional care. But I think a lot of people are changing the way that we look at these. There's a lot of incidences that are happening in these settings. There are a lot of challenges with staffing and not being able to provide them the right resources to live and age gracefully and with the right dignity and care that they deserve. And so a lot of new programs and policies are being created to allow for aging in place. Right? The idea that you can live in your home and be able to eat the food you want to eat, be able to see your friends and family, be able to continue to care for pets and live with neighbors surrounding you and have a supportive environment. And so now the question is, how do we make that environment as supportive both for health but also for social care needs, right? There's a lot of things like, how are they going to get their medications, or how are they going to get their meals on time? How are they going to get transportation to different facilities to see their providers, or can they just actually see the providers in the home with things like telehealth? And so I think we're starting to reimagine what the home is, beyond just the four walls. It can be a place where you can get care, get food, get social connections, get the kind of stimulation to be active and continue to be purposeful in your life. And I think that's kind of the things that we're seeing with groups like KP, looking at how can the home be that setting for you to get the care you need. And so I'm excited to hear what else ideas you have, because it's certainly an area that we have to innovate more in. I think the next question is around payment models, right? How do we continue to support financially these different settings? So
How do we keep the lights on?
yeah, the lights on. So,
Apologies for that.
thanks.
That's funny.
Yeah, good answer. So I think that we're very aware, right, that Kaiser Permanente, we have a national footprint. We're not nationwide, but we have a lot of buildings. We build a lot of buildings. They're very expensive, and the reality is that nobody wants to visit them, right? Nobody wants to go to the hospital. Nobody wants to stay in the hospital. Everybody wants to experience their care at home, and so that trend is only intensifying. And as people are living longer, and I think the root of the question, really thinking about how we manage chronic conditions, that is going to obviously just become a bigger and bigger issue. People are going to develop more and more comorbidities. They're going to have lots of chronic conditions. So I think that we are right now imagining, like, what does care in the home look like? What can we do with technology, with sensors, with telehealth? We just are launching what we call an Advanced Medical Care at Home, or AMCA project in Southern California. And this is a huge kind of flagship model for us, where we start to imagine, like, what does hospital at home really look like? And how do we just keep people, even that would would traditionally need an inpatient setting, would need to stay in the hospital for several weeks, we can do all of that at home. I think that there's some really exciting opportunities that we're just starting to kind of scratch the surface of with imagining how artificial intelligence and other modeling programs can really tease out. Historically, people that have chronic conditions, right? We treat the chronic conditions as they show up, and that is, Kaiser having a preventative care model. That is the inverse of what we attempt to do. So really trying to do a better job of identifying with AI, with other tools, the people that maybe have not developed those chronic conditions yet, looking to surface the folks that haven't been in for a year or two, but we know people like them with histories like them are going to trend towards chronic conditions, right? How do we do more direct outreach to them earlier in the process, especially if we haven't seen them in a year or two, to say, hey, you should probably come in and just get some tests done, and let's try to prevent that chronic condition from happening. Let's insert ourselves in the conversation and do a better job of managing your health today so that you do not have to develop these comorbidities later, right, which makes your care that much more complicated. I mean, this is one example, but I think that you're absolutely right. I think that the direction of care needs to move into the home, and we're doing a lot of work in that space right now, and it's really exciting, I think.
And I think these are all excellent points. I think if you could just imagine how many people that are aging in place are living, suburbs, houses, they're living alone, very difficult to reach neighbors or reach their friends without an automobile in many, many cities across the United States. And you think about the ratio of thinking about say, liquor stores to treatment centers for substance use disorders. I'm putting my addictions hat on and mental health hat on. Like these wellness spaces for wellness are few and far between, right? Like thinking about public libraries, there's only one per city versus say liquor stores or other venues that can cause a lot of issues. So when I think about all the sort of chronic conditions that could affect people, I think that having it at home is absolutely important. Telehealth, continuing telehealth is important, and then continuing protections for telehealth and reimbursement for telehealth, and optimizing these technologies. Not everyone has broadband, not everyone can speak the same language as their provider. We need to have essentially technologies that can help with the access issue to folks who may speak a different language or have a unique culture that can help them achieve the goals that they want. So those are some of the thoughts I have with mental health and addictions. When it comes to sort of these chronic conditions, having at home technology can really play a role here.
Yeah, you can keep it. I can talk here, but I guess I'll throw a little curveball because I think I want this one to be a conversation, and then I know Tommy talked about like the growth of AI in this kind of space, and then we also talked about like access. So like I guess like we all seen like these past couple months like ChatGPT and generative AI really growing, and then do you guys see any like kind of like the use of those technologies in this space, and then do you have any issues like maybe on access or anything else? I guess.
Sure. So we were talking about COVID-19 and some of the work that you've done, and so this is something that catches my attention is how a lot of people are afraid of chatbots, and also just from an ethical standpoint, what kind of things could be said by this said chatbot. In fact, there was a news article about how one person apparently spoke to a chatbot that didn't have the proper protections in place for the language, and it ended up encouraging the user to take their own life. I'm not sure how that happened, but their language model must have been really not very well refined. At the same time, so thinking about the basics, where we were at 2020, COVID-19, chatbots were absolutely needed and essential. A lot of companies, a lot of health systems deployed chatbots to help guide patients, because early on, emergency rooms were overwhelmed. People were coming in with the same set of conditions, same set of questions. Should I go to the hospital or should I stay home? How many days that sort of thing. And so all of these sort of algorithms can be essentially deployed as really usable chatbots. I think for mental health and substance use disorders, it can be helpful. It's something that we would have to really be very careful about. But when it comes to a lot of our conditions, we already have questionnaires, for instance. We have a lot of the things, like for instance medication side effects that can be asked. A lot of those can be simple patterns that can be codified into sort of chat flows. So I do see certainly a role. We just have to design it well and incorporate clinician input.
Yeah, ChatGPT is fun. But I would say generative data in general, I think we've been using it for a while now, I think especially around imaging and sort of creating data that we're using to run through models, right? So there's a recent example that we're working on is, frequently for dermatology related issues, right? People will have a question, they'll take a photo of something and then they send that to their doctor because they want to what is this mold? Right, but oftentimes people are not very good at taking pictures of themselves and their skin, and oftentimes that photo is blurry to the point where it is useless to the clinician who's trying to make a diagnosis or determine next steps. So we've been using generative data to essentially train models to look for blurry images, to look for out of focus, so that we can alert the person taking the photos, try again. If you really want an answer, you need to try again. And so I think there's huge implications for this. That's just a very basic surface level example, but I think that we're just starting to scratch the surface of what's possible with this.
Yeah, I think it's really exciting. Obviously we're getting there. I think when you think about automation in general, think about the self-driving cars at the far end here, right? And then the drive yourself car, or Flintstones, you pedal yourself down. That's on this side. So I think we're a little bit in the middle. If we can use technology and AI and ChatGPT and all these other automation things to support or amplify the workforce, right? That's one of the biggest issues right now is how do we help reduce the burden of workforce? How do we enable them to be smarter or work more efficiently or more effectively? And so I always tell people trying to innovate in this space is how do you just enable and support the person-centered care that's still really critical, especially for older adults, right? I work with older adults all the time, and so that's kind of the focus I have. But I guess I myself am a millennial, so when I call these phone lines, I don't want to talk to a robot, right? I want to get, how do I get to the person as fast as possible? So I try to press 000, or I say, agent, trying to get to the person that answered me. But Gen Z or people younger than me might be okay talking to a bot for a while. So think about who you're designing for. Think about how you can amplify the workers or empower them or enable them to do more with these kind of other algorithms and other ways to reduce the amount of burden they might have otherwise, right? For example, taking notes, product notes, or doing assessments, obviously a great way to get data and assess without having to use people. Thinking about some processes I met some social workers who literally stayed on the phone with older adults for hours trying to help them register for SNAP benefits, right? That shouldn't be something that we spend social workers' time doing. If you can automate that and reduce the time and use technologies to increase the workflow, all of a sudden that social worker can help other people that need more help, right? So I think it's finding a balance right now, keeping the person in the middle, supporting person-centered care, but obviously increasing efficiencies and effectiveness through these technologies is a great way to look at this right now.
One extra thing you made, because you reminded me of this. One thing I'll say is that there's a danger, there's a recurring sort of theme around, especially around automation and sort of clinical workflows and things that, especially I'll just say in primary care, right? We've done a really good job over the years of essentially automating out the quote unquote easy cases of a primary care schedule. And so primary care providers that's kind of ground zero for physician burnout. So there's this weird slippery slope with thinking about how we use automation and AI to really help augment clinicians' workflows, to take the easy stuff away so they can focus on the complex stuff. But the reality is that easy stuff is actually how clinicians are able to tolerate doing the complex stuff, right? Because, and so I've spent a lot of time working on clinician burnout, even the year leading up to COVID, ironically, right? And then that was something that we constantly saw with our clinicians, right? Is in primary care, the number of folks who are opting into early retirement in their 40s and 50s because they're checking out. They can't do it anymore. So it is really, I think, it's important to consider know your users and who you're designing for. It's critical, but also just understanding that we need to do a better job of sort of panel size and supporting our clinicians, and not just trying to like take all the easy stuff away from them. Yeah.
That's super fair. That's super interesting what you said about like clinician burnout and all that. And I guess like a lot of people may think like these kind of AI like tools might be like replacing jobs, or like I think there are some clinicians like their concerns about that. Would you guys think that that is a concern, or maybe it's more of a tool, like you said, that like for the easy things instead of like the complex?
Our unions would certainly say that it's a concern. That's what I would say. Yeah, I think there's definite workforce implications, right? So you just have to be sensitive to that on the staffing side. But I think that there is your social worker example is perfect, right? We need to think about like how to best optimize these really talented people, right? How can we make sure that the other thing that I think we hear a lot is top of license, making sure everybody's practicing at top of license, and that's also kind of a little bit of a trap, because if everybody's working at the top of their license, 24 hours or 8 hours a day, they're gonna burn out super fast, right? Because you need a balance, right? Or you need a mixture there, but.
Real quick on that, I think it's also readiness, right? Who you're designing for, are they ready to jump to, 100%? We work with community health workers, and we're taking a simple process like documenting and coding, and for them, this was something that was done on spreadsheets and paper checklists and notepads. So for them, we can't go to automation too fast, where we have to just help them do their work more efficiently, more effectively. Other professions or other people in the healthcare field may be ready for more advanced skill sets, and you can jump to these things. And for them, workforce, for the community health workers, being able to bill and code now enables them to get reimbursement. And for them, that means higher wages. They can actually get incorporated into the healthcare system more readily. We're going to see more health plans and providers actually incorporate them into the team-based care model. So for them, it really is empowering, and it's enabling them to utilize their skills and talents of building relationships and doing care navigation, and doing it in a way that empowers them.
Yes. So I'm hearing the incremental baby steps, and it makes total sense. We think about all of these, say mental health companies that try to really get ahead of the game. I'm thinking about Mindstrong, for instance. About 6 years ago, they introduced the concept of just detecting issues with cognition and such based off of your keystrokes on your phone. But they ended up transforming into a telehealth company because they couldn't really get their technology purchased by anybody, or they had very few customers, it seemed. And the company ended up folding, and they were headed by the head of NIMH, which is the National Institutes of Health, National Institutes for Mental Health, NIMH. So that was something that was an idea that was ahead of its time. I think that for us, we were thinking about things that may not seem like totally revolutionary, but it's those incremental steps that really allow us to, continue progressing. We do need to have those steps though. So.
Nice. Yeah, thanks for sharing that. I guess we can maybe move on from AI, and then maybe you guys can, like, beyond just AI, like, are there any innovations in the past, like maybe like 2-3 years that you guys are really excited about in your respective spaces?
I am quite excited about how mental health care and substance use disorder care is delivered in between sessions. The traditional model has been go see a clinician and then just see them once a month or once every 2 weeks or so. But what I'm seeing are things like Microsoft Viva. Microsoft Viva is this whole concept of a suite of products that they're weaving into Microsoft Office. One of the most not Microsoft Office, Microsoft 365. And you'd think that that's not like a mental health or wellness sort of app or platform, but it's weaving those principles into everyday life, meeting people where they're at, in their email inbox, or even on Teams chats and such like that. So it's interesting to see these mental health principles being woven into everyday technologies. One of my friends runs Stanford Brainstorm, and they've consulted with companies like Pinterest and TikTok and so forth. And they've been able to have a say in how mental health is not delivered but communicated through their technologies.
I think innovation-wise, I think one of the things that we're starting to see is, sensors have been around for a long time. Everybody's got one on their wrist these days, right? But I think when we think about moving care into the home, sensors have always been a bit of a problem, right? Because you think about people want to stay in their home longer, when they develop conditions and they need to have some type of monitoring, right? We're really having to deal with, grandma's Wi-Fi, right? How, and whether or not she has appropriate bandwidth for this, right? How do we remember to charge all of the sensors, charge all of the devices, who's gonna support it, how do we deal with it? That's always been kind of the Achilles heel, and we've really been ramping up, various remote patient monitoring programs to really try to, empower people to stay in the home and to move into the home. And I think there's been a big proliferation of what we call passive sensors now, right? So sensors that people don't need to interact with, right? So there was a really terrific one recently that we've started working with, right? Which essentially looked like 4 hockey pucks that would just go underneath 4 posts of the bed. And just get a patient who might have COPD, might have some other chronic condition where you need to monitor them 24/7, and all they had to do was get in bed. Everybody knows how to lay down in bed. Laying down in bed automatically takes your weight, monitors your breathing, your respiration rate to a scary degree of accuracy, and also monitors heart rate and all these other vitals, right? Just by being in bed. And from a clinical perspective, a lot of these signs about breathing, around heart rate, it's best at rest, right? So the fact that we're able to pull all of this data in at rest on a regular basis without them having to do anything has really kind of changed how we're thinking about being able to keep people in the home longer, but also being able to have our care teams, our home health teams, and others know when to reach out, right? If there's some anomaly, we can do that sort of proactive outreach, know to send people into the home. I think that sort of passive technology where we no longer have to have somebody in the middle, right, trying to support those devices is going to be huge. I think it's a big unlock.
Maybe a quick follow-up question to sensors. I think we've seen a lot of wearable technologies like Apple Watches, there's a lot of research here, especially at Stanford, with kind of wearable sensors that are like tattoos, and you just put it on your skin, and then, or even like microneedles. I guess you don't see too much or do you see any promise in that, or is it too difficult to implement in these kinds of things?
No, I don't think it's too difficult to implement. I think a lot of that stuff is still, I don't want to say early, but I think a lot of it hasn't sort of reached that critical mass yet, right? I think what we have started seeing, I think our pharmacy teams in particular are very, very interested in a lot of those things, especially like time release, the tattoos that can sort of time release drugs in through the skin. There has been sort of small tests of change with some of those things. I know that KB, we have our own venture firm, right? I know there has been some investments made over the years in that technology. We definitely believe in the technology. I just think that it hasn't quite sort of reached that adoption point yet. But yeah, I think, we're doing a lot with Apple, we're doing a lot with Fitbit, we're doing, in Google and others, right? So I think from a general wellness and health perspective, there's lots of interesting things, but I think especially, with moving care at home, thinking about aging, in particular chronic conditions, that's where sensors, I think, have a really amazing sort of potential to make dramatic changes in people's lives.
I love hearing the industry perspective on these things. It's coming from the entrepreneur side, trying to get into some of these health systems and trying to innovate and test things out is sometimes very difficult, but I'll get to that.
We make it easy.
Yeah, I totally. So I think I always tell entrepreneurs and people that want to innovate that innovations don't have to be technically difficult, right? It can be simple things that are innovative solutions. So for example, one of my favorite companies that it hasn't gone too far, but it's this company called Silver Pulse. You can literally text a picture and a message, and they'll send a postcard to your loved one. automatically for you, because the idea that you can have to sit down and write a postcard, get a stamp, find a mailbox, it's so hard. But for them to be able to just take a picture of something, you send your grandpa or grandma a picture of yourself and say a message, and to get sent to them automatically is a great way to stay in touch with them, right? But it's super simple concept, super easy to execute, but it doesn't take a lot of technical complexity to it. The idea that art therapy now is being incorporated into a lot of therapeutic methodologies and trying to bring joy and love and care and socially through art is a very simple concept, but yet technology can enhance that and enable that to be really successful in healthcare. Food as medicine is another one, right? It's a simple idea that food can be supportive of your well-being beyond what medications or therapies or any other operations could do. The challenge, though, is, and this is something that sometimes entrepreneurs forget about, is someone has to pay for it, right? Who's going to pay for it? Who's going to actually shove the money to make this worth it? Is it the end user? Is it the health plan? Is it the provider? And if it's the end user, is there a health equity issue there, right? Because not everyone can pay for these things, right? Sensors are very expensive. Not everyone can afford sensors in their home and cameras. And so all of a sudden, you're now leading out a big population that probably needs it the most. So how do you balance health equity as well as innovation? And how do you get the right people that are actually saving a lot of money to pay for this stuff? And that's everyone's kind of, even the companies now that are doing kind of B2C markets are going to the consumer, they're eventually going B2B to the health plans because we know that we're saving them a lot of money. Getting there is a little difficult when sometimes these health systems, health payers, aren't willing to test things out. And thinking back when I was in senior living, our company would never let any sensors, anything that was remotely litigious and risky into the facility. We wouldn't let any sensors in. There was a cool company that came that could detect UTIs by putting a sensor in Depends, a diaper pad for older adults. And it was like, if there's a chance that it can cause harm or cause it to be back on us as being at fault, and we get sued, now the company's gone, right? So I think we have to find a mix between how do we get innovations into the setting where we can actually test it out, get the right data to show that this has an ROI, because that's what's going to get the health plans to get on board, right? Health systems will start paying for this. If we can't get over that hump of overcoming the litigious field of healthcare, we'll never get the data to show that it makes financial sense. And then we pencil out, and we won't be able to innovate beyond that. So finding a balance between those two is really important.
Yeah, I guess maybe on like the opposite side of the spectrum from like kind of these innovations, like maybe some of the challenges that you guys are really interested in. I know we maybe talked about some of it, but yeah.
Some of the challenges that we're very interested
Yeah.
in. So from my standpoint, I think it's there's a bit of it would be reimbursement. Some of it is policy. We can create wonderful technologies, wonderful solutions, but if we can't get it, can't get it in people's hands, or if there are laws against using such technologies, then it's all for naught. So some of the challenges I think are keeping tabs on the industry, but also ensuring that people don't burn out with these technologies, and communicating the benefits and making it really easy to onboard people. So that's partly why the company that I've co-founded is essentially looking at something that's very simple. So people do this all the time with selfie videos and capturing their own thoughts on their phones. So why can we not use that for psychiatric interviews or psychiatric diagnoses, things like that? So that's this is one of the challenges that we're thinking about in this space.
The challenge I think I'm the most passionate about right now, that I've spent a good chunk of the last couple of years working on, is really around caregiver support. So thinking about informal family caregivers. I think some of the last estimates that like AARP ran pre-COVID was like 25% of Americans are in a caregiving role, right? And I think a lot of people, and I think that number is grossly undercounted, because I think a lot of people who are in a position of whether they're taking care of their parents or their siblings, they just don't see themselves as a caregiver. A lot of people, it's cultural. They grew up with grandma and grandpa in the house, and as their parents age, it's just expected, or it's expected of them, so they're taking care of their parents. They don't see themselves as a caregiver. They're just doing the right thing, right? Or they're just sort of taking care of a loved one. But so I think as a health system, right, we frankly suck at identifying people who are in caregiver roles and figuring out out how to support them and get them the tools. They don't always show up in the exam room with their loved one, right? Sometimes the loved ones are very private about their conditions, right? They don't want it to be known, and so as a result, we can't go actively reach out and help these folks. And caregiver burnout is a real thing that people struggle with, and so it's in our best interest, especially as we are talking about moving care into the home, people wanting to stay in the home longer. That one of the sort of second order effects of that is that more and more people are going to find themselves in this caregiving capacity, right? A lot of our job is going to end up being done by family members because people are staying home longer, right? So how, as a health system, can we do a better job of not only identifying the people, but also then giving them the tools and the resources that they need to take care of themselves and to make sure that they're doing as much as they want to be doing to help taking care of their loved ones, right? And helping their loved ones sort of age with dignity in the place that they want, in the way that they want. So I think we're doing a lot of work in the space now, but it's like, we're barely scratching the surface, right? And so I think that's a challenge that I'm super passionate about and want to spend more time in. You have a question?
I'm gonna ask a question.
Yeah, for sure.
Wondering, like, once you've identified the population, like, what are you actually doing from there? I mean, it sounds like one of the huge challenges is identifying just like not serious who's a parent, right? But yeah, wondering, like, let's say you do have like a 50% increase in the ability to identify them. Like, what are sort of the things that you all are looking at?
Yeah.
And integrating to actually helping those family caregivers.
Yeah, so we're actually so I'll say that there's some buckets of opportunities, right? So there's one big bucket that's just around education, right? I think post-diagnosis of whether it's Alzheimer's, dementia issues. Sometimes there's a real challenge with empathy, right? And trying to understand, and trying to give the caregivers the tools to understand. This is what it looks like today, but this is probably what the roadmap looks like. This is what the journey looks like, right? So here are the things that you should be looking out for. These are the things you should be preparing yourself for, and these are the ways that we can help you at all of these stages. So a big part of it is education. There's another big channel around just general support, right? I think oftentimes being a caregiver, I had somebody explain to me that being a caregiver was like asking yourself 1,000 questions a day and having no idea what the answer to any of those questions are, right? You're constantly questioning yourself, is this right? Should I be doing something differently? Can I be doing more? Right, that's just sort of the day in the life. And providing more direct outreach for those people to be able just to pick up the phone and call, because again, that's not something that today there's an obvious way for them to do. And even if unless they're a Kaiser member themselves, in my case, and they call up and say, hey, I need support for this thing, there's no like 1-800 Kaiser number that says I'm a caregiver for this other person, right, and I need help. So a lot of it is just internalized. It's Google searches. It's random event or random data out there to try to support them. So there's a big opportunity there just around sort of support for those, emotional support, and just helping to identify community resources and other services that either we offer or that we partner with to provide support. And there's a lot more that we could be doing, but I think those are kind of the big buckets that we've been spending some time on recently. Yeah.
Can I ask a question? Also, because I think one of the things I think about caregiving is cultural support
Yeah.
to families. Because I come from an Indian family, and my grandparents aged in place. My father took care of him through his end of his life last year, and one of the biggest things that we needed was cultural support, like an Indian family that can come in, or Indian
Yep.
caregiver that can come into the home. And it was really hard to find that. So, I mean, what are some things that Kaiser's doing? My whole entire family's a part of Kaiser. We live right here in Redwood City, so we're part of the Kaiser system. So I'm kind of curious, like, what are healthcare systems? This is a huge need,
Yep.
given how multi-diverse our communities are becoming in the future. And there's gonna be more people beyond the age of 65 in like the next 10 years.
Absolutely.
So how are you gonna support all of them?
Yep. So I think there's a big opportunity there around culturally specific care, culturally sensitive care, right within our health education teams. So one of the things that Kaiser does, I'm not going to say we do it perfectly or that we do it great, but I think there's a big opportunity for improvement right within our health education teams. And the way way that Kaiser is sort of divided up, right, in this area is like a service area, and that service area understands what their population looks like demographically, right? And then they start to try to build out the resources to best support those populations, right? So the services that are needed, like in Menlo Park, or the services that are needed in Sunnyvale, or or in San Jose, are going to look different. And so those health education teams, to a certain extent, are empowered to try to build out what those services look like. But that is, in particular, with caregiving, right? That has been a topic that we have talked about a lot with, when we go talk with startups, for example, right? There's a huge opportunity beyond English and Spanish,
Yeah.
right? It's a really difficult challenge. So I don't want to minimize it. But oftentimes when we're talking to entrepreneurs and startups in the space, everybody starts with English, and Spanish is next. And so that's kind of like, okay, well, that's great, and we can run some tests with that, right? But what we really need to get to is, for critical mass, it's like a dozen more languages or more, right?
Well, we had such a hard time finding caregiver or
Yeah.
home health support.
Yep.
People who spoke Hindi who can support my grandparents. So I mean, obviously my family were all
A lot of-
before me, but it was so difficult.
It's difficult, and a lot of that today can be done through translation services, but that is impractical and it's
Yeah.
impersonal. And so, yeah, it's not the right way to do it, but it is kind of, for the last couple of years, has been a big gap, right, in home health. We do some of our own home health, and then we partner with other agencies, but there's a huge gap there.
Thank you.
One question I had was, I guess based on my understanding of payers, just PMPM per member per month is a big number that payers care about. But the economic value also has to be there. I just wondered on this topic also, the caregiver 25% being in the U.S. population, what type of economic data are you seeing that are positive signs to support that from a payer perspective? And the second question I had, maybe from the technology perspective, we didn't talk so much about FDA, which plays a big role in actually technology becoming very, very real. So just wondered how you think about that, or you were thinking about those things.
I'll touch on the PMPM thing real quick, and maybe let you guys talk a little. I'm very thankful in my role that I don't have to deal with the money part. I wouldn't be good at it, but I'm very thankful I don't have to deal with that. But what I can tell you is the way that we look at caregiver support is that it doesn't matter, that person that we're supporting, the reason we're supporting them isn't because whether or not they're a member, it's because they're helping to support a member, right? So I think that there's an interesting Venn diagram of sorts, right? Because we have KP members who are caring or in a caregiver role for other KP members, right? So it's a net for us, right? It's like we're caring for everybody regardless. But you definitely have non-Kaiser members who are caring for Kaiser members. We still need to support them, make tools available for them, make sure that they are not burning out, not having issues, because ultimately that has negative impacts for us, right? For our member, their experience, but also for us as a care system. And then you have Kaiser members who are caring for non-Kaiser members. And in all of those equations, it's all equal. Like we sort of are, the way that we're approaching it is equal. We can't look at, because then we get into equity issues, we get into other things, right? And it's against sort of the mission, if we're gonna look at it from that perspective, right? It's getting away from the mission of what we're trying to do. Hopefully that answers your
Thank
question.
you.
I can speak about the FDA survey. So the FDA question, U.S. Food and Drug Administration, it's one of those things where we talked about earlier, where it's like, well, the technologies and the things that we invent are influenced by policies and reimbursement, and so this would fall under the policy realm. What is allowed on the market and what is not allowed? So, you can talk about the story where you go into your local grocery store and you see all these shelves of nutraceuticals and nutritional supplements, and you can just grab it off the shelf, right? Then there's over-the-counter medicines. You can just buy acetaminophen, ibuprofen, and then there's the pharmacy. There's a sort of a gatekeeping role there where you have to get a prescription, and if it's a controlled substance like benzodiazepines or opiate pain medicines, that has another layer of protection. So you're seeing this with the FDA, where it's like, okay, with say digital medicines or digital therapeutics, you know, people have talked about prescription digital therapeutics, PDTs, where you need to have a prescription from a clinician or a physician or a nurse practitioner, that sort of thing. And then there are over-the-counter digital therapeutics where they actually don't have to have that FDA approval. Right now, I think a lot of folks are using the FDA route as a marker of quality, but there's also because there's no real other body out there that's saying, like giving a seal of approval, that you know, that vouches for the quality and the safety of these digital medicines. So that's why a lot of folks have gone the FDA route. At the same time, if you go exclusively that route, then you risk losing access, where maybe someone does need access to a digital medicine, but they can't pay for the clinician and they can't go that route. So you basically have this sort of tug of war between the two. Some companies have gone, you know, approached all of the above and like changed the terminology to make sure that they don't have the right treatment claims for the digital therapeutic, and so they can skirt those regulations. It's a really interesting area that's still changing, I think, and so the fact that it's changing means that companies are also unsure where to go, and so this year I feel like we're seeing some digital therapeutic companies not doing so well, and potentially even fold. So
Yeah, I guess one final question. Thanks, and I guess yeah, like, do you guys have any tips for our participants over the weekend or next weekend? Kind of like maybe like you guys talked a lot about the challenges and like some of the innovations. Yeah, if you guys have any like tips for like.
Sure. I did my first hackathon 10 years ago. It is so much fun, but it's also can be very, very scary because you've got a time limit, you've got like no sleep, there's a lot of sugary snacks and coffee. You want to take care of yourself, make it a good, you know, don't put too much pressure on yourself too. Make sure you make lots of friends. It's one of the things I loved about the experience of, I was doing some hackathons for, it's Health 2.0, now it's part of HIMSS, and just getting to meet people who all had different superpowers, combining their talents into this awesome product and being able to talk about it and share it on stage, lots of fun. So I'd say, you know, have fun, but meet lots of cool people, enjoy yourself too.
I think you're going to give a good answer. But I would just say, don't overthink it. Don't make it too complicated. He's already given you several of the right answers, right? I think be super understanding of who you're designing for, solve a very specific problem, yeah, don't overthink it. It doesn't have to be complicated, because I've looked at lots of startups and lots of companies who clearly overthought it, and it's almost like unusable at that point. So I would just say keep it simple and have fun.
Yeah, go many places here. I think, you know, there's a lot of money in healthcare. There's a lot of problems in healthcare, and so the simplest problem, like people have mentioned, could be a really big market opportunity. And you know, there's a lot of. I mean, I think previous to COVID and even before that, healthcare was in the hospital, right, in clinics. Now we're seeing like healthcare in the homes. We're seeing healthcare like COVID-19 pandemic. It wasn't the hospitals necessarily just giving COVID shots in hospitals. It was them giving COVID shots in the community, at pop-ups, at churches, at restaurants, at grocery stores, wherever they could to meet people where they're at. And so really the healthcare system has expanded beyond the walls of the hospital into schools. If you ever looked into the community schools model, it's all the idea that the school can be a hub for resources and services and food, and in your haircuts there you can check for, you know, bed bites and bed bugs and get the resources you need. So think about that. If you haven't looked into the social determinants of health, this is a big area that healthcare is trying to move into. Everyone's trying to figure it out. It's the idea that things like transportation, housing, education, health literacy, these are just as important, if not more, than the healthcare delivery and the access you have to healthcare. Then, you know, so how do you incorporate that into the healthcare system? I think there was a statistic like 80 to 90% of medication adherence is not due to the wrong medications. It's actually due to them not knowing what they're taking, why they're taking it, some kind of literacy issue, not being able to get the medication to begin with, some kind of confusion, maybe vision could be an issue because they can't read the bottle. So how do you start to solve for these other social determinants of health that can eventually affect health outcomes? So consider that as well. I'll also say my last thing is, I started a company before PearSuite, which didn't go very far. It was medication adherence. But I learned so much from that experience and the failures that led to successes in the next round. And now we're venture back. Now we're doing a lot of revenue. But if I didn't try that first time and fail, I wouldn't have got to the second point. So I tell people all the time, don't wait for the perfect idea before you try and build and try to get it out there and test. You have to get things out there. You have to learn from your mistakes. You have to talk to more people, do the interviews, do the iterations, because that's going to lead to a better product at the end of the day.
Thank you all for your advice, and let's give a final round of applause thank you everyone for showing up here, and then we'll see you next week for our event. And we also have another speaker series next Wednesday. So please, we'll have it's for our population and preventative health track. So thank you all again for coming out. See you.
And thank you all.
Thank
It's
you so
amazing.
much.
Amazing.